The following podcast is part of a certified educational activity titled Lower is Better: Novel Therapeutic Strategies Targeting PCSK9 for Reducing LDL-C Levels in Patients with Hyperlipidemia and ASCVD with Professor Kaushik Ray, Dr. Alan S. Brown, and Dr. James A. Underberg. Access the entire activity and complete the post-test at peerview.com/KXB860. Downloadable slides and practice aids are also available.
Welcome to this CME event, PeerView Live, entitled Lower is Better: Novel Therapeutic Strategies Targeting PCSK9 for Reducing LDL Cholesterol Levels in Patients with Hyperlipidemia and Established Cardiovascular Disease. So, my name's Kaushik Ray from London, and joining me are my friends and colleagues, Drs. Alan Brown from Illinois and Dr. James Underberg from New York City. Jamie, welcome, and the floor is yours.
Well, thanks so much, Professor Ray, and thank you to the group at PeerView for including me in this wonderful program. Should be a lot of fun. And I'm going to get things started off with a discussion around treatment standards, guideline recommendations, why we're doing what we're currently doing, essentially. And I always like to begin with reminding everyone that LDL cholesterol is causal in atherosclerosis. There are several different lines of evidence that support this. It's not a hypothesis, it is causal. And we look to a variety of different sets of data to support that. And the first is our observational or prospective cohort studies. And you see that as evidenced here in the middle of these three graphics. The patients who seem to have higher cholesterol levels have a greater risk of CHD, and those with lower cholesterol levels, a lower risk of CHD. Randomized trials where we actually intervene with lipid-lowering agents, and in most cases statin, but we have evidence now with non-statin agents too, remind us also that the lower we make LDL safely, the lower the risk of cardiovascular events. And then finally, the curve on the top, the steepest curve, is that from genetic data, Mendelian randomization studies, reminding us that patients who have very low LDL cholesterol levels from birth have very low lifetime risks of cardiovascular disease. And what's fascinating is the degree of steepness of these three curves is directly related either to the exposure to or the removal of the offending risk factor, which in this case is LDL cholesterol. So the longer you're exposed to high cholesterol over the course of your lifetime, the greater the risk. But the longer you remove that risk for, and that may actually impact treatment, we'll discuss that a little later in this section, the greater the risk is reduced. And so again, I think this is one of the most important slides I'll show today, and it really sets the stage for why we're doing what we're doing. And if we look at a meta-analysis, in this case of statin trials, we're reminded that patients who achieve lower LDL cholesterol levels have a greater reduction in major cardiovascular events. And this is significant all the way down to LDL cholesterol levels less than 50 milligrams per deciliter. Now, this does not mean that if you take someone's LDL from 55 to 48, you necessarily have made a difference in their risk. It simply reminds us that lower achieved LDLs are associated with lower risk. And so understanding all of these concepts brings us to the current state of where we are in the primary prevention of atherosclerotic cardiovascular disease. And I'm going to focus on the most current U.S. recommendations. These are really a multi-society group of recommendations led by the American College of Cardiology and the American Heart Association, but truly multi-organizational in groups such as the National Lipid Association and a variety of others have been involved in not only creating but endorsing and promoting these recommendations and guidelines. So if we think of the primary prevention cohort, I think the first thing to understand when we think about this is that there are a variety of different groups and ways to think about risk in primary prevention. And I think we focus primarily on the patients between age 20 and 39 and those between 40 and 75. And the first and most important component of evaluating these patients is to estimate risk for cardiovascular events. And in the younger patients, it's important to think about lifetime risk, not just shorter-term risk the way we do in older patients. In the patients between age 40 and 75, we initially focus on 10-year ASCVD risk. But for the first time now, we're actually given excellent guidance for those patients with lower ages between age 20 and 39, that if they have elevated LDL cholesterol levels greater than 160 milligrams per deciliter, or a family history of premature ASCVD, consider statin therapy in these patients, going all the way down to age 20. And again, estimating lifetime risk in these patients is so important because 10-year risk is impacted significantly by age. And so in younger patients, if you calculate 10-year risk, no matter how many risk factors they have, often their 10-year risk assessment is going to be very low. And you don't want to miss something that may impact risk over the course of the lifetime. Now, when addressing risk, it's important to think about ways to estimate risk. And I think one of the key components of this is the ACC ASCVD risk estimator. And this can be downloaded to a mobile phone. It can be used in a desktop setting, which is what I'm showing you here. But just to remind you, the components of this are age, sex of the patient, and for the first time now, race, systolic and diastolic blood pressure, total cholesterol, HDL cholesterol and LDL, history of diabetes, smoking, whether or not a patient is on treatment for hypertension, on a statin, or on aspirin therapy. And all of these impact the patient's 10-year risk. And again, estimating this is key and important because it allows us to have a discussion about risk with the patient. We don't just give them a number, but we tell them the components of that risk so they understand that their risk may be primarily driven by their smoking or their blood pressure. And so these are things that are just as important to impact as lipids, even though we may be focusing on lipid management. And so again, when we come back to these recommendations and guidelines, it's just as important to understand that once we calculate risk, especially in those patients between the ages of 40 and 75, if their risk is low, the key is a risk discussion emphasizing lifestyle behaviors and how to modify them to reduce risk. And that's those who have a risk less than 5%. If their risk is high, greater than or equal to 20%, well then that risk discussion is certainly important, but it does focus on getting those patients started on statin therapy ASAP. However, what about patients that fall into the borderline or intermediate risk category? And there sometimes we need some additional risk stratification, both to help us and our patients make decisions around treatment going forward. And now for the first time, the guidelines allow us to consider using coronary artery calcium scoring. And if someone has a 0 score, that lowers risk, and you could consider no statin, unless, of course, a patient has diabetes. And I remind you that for patients who have diabetes in the primary prevention cohort, the recommendation is moderate intensity statin for all of these patients. You can further risk assess diabetic patients, and if they have additional risk factors, then high-intensity statin therapy would be reasonable in patients with diabetes without heart disease. We also have the group of patients over here on the top whose LDL cholesterol is greater than or equal to 190 milligrams per deciliter, essentially patients with familial hypercholesterolemia. And like the patients with diabetes, they don't undergo risk assessment because the nature of making the diagnosis imparts the high risk associated with this condition, and they should be begun on high-intensity statin therapy. But again, using coronary calcium scoring, if the score falls between 1 and 99, this favors statin, especially above the age of 55 and above 100, or if the patient is greater than or equal to the 75th percentile based on age and sex, which is very important. You can have a woman in her 50s with a score of 10, but that would put her in a very high percentile based on her age and sex. then you would consider initiating statin therapy. And again, the groups for whom coronary artery calcium scoring makes a difference when it comes to reclassifying risk up or down is in that group whose 10-year risk is between 7.5% and 20%, but also between those patients in the 5 to 7.5%. And so again, you would consider statin if that CAC score was elevated in the 5 to 7.5%. You would recommend it in those 7.5 to 20%. And so again, in the low risk and the high risk populations, it's not going to be effective for further reclassification. It's in the middle where it really makes a difference. And this is a great slide. Scott Grundy published a nice overview of who might benefit from knowing their coronary artery calcium score was 0. And you can see here a couple of different groups where I think this is reasonable. Patients reluctant to initiate statin therapy, who want to understand their risk and benefit a little more clearly. Patients concerned about the need to restart statin after having failed due to statin-associated symptoms. A little more reluctant, but if the risk had been established as being higher, then I think people might be motivated to try additional statins if they had problems with one. Older patients who fall into a higher risk category primarily because of their age, but are otherwise well, may find this useful. And then obviously the middle-aged patients where the pooled cohort estimator puts them into that 5 to 7.5% category. But the guidelines give us additional tools for evaluating risk in primary prevention, and those are these what we call ASCVD risk enhancers on the left. And these are emboldened in red, and the reason why is because I think they're so important. The first reason is because at least half of them are things that we get just from doing a good history and physical. And I can't overemphasize how important it is to spend some time talking to your patients and doing a good physical exam. And then the second half are some lipid biomarkers that are not required to be measured in every patient, but you can consider measuring some of them or all of them, depending on the particular patient, and they may further help you in the risk assessment of that patient. And so what are some of these risk enhancers? Well, family history. That's key and important. It's so important to ask about this. Primary hypercholesterolemia, right? Is that LDL greater than 160, or is that non-HDL greater than 190 milligrams per deciliter? Metabolic syndrome, right? Increased waist circumference, abnormal glucose control, elevated blood pressure, chronic kidney disease, chronic inflammatory conditions such as psoriasis, rheumatoid arthritis, lupus, or HIV/AIDS. A history of a variety of different obstetric and gynecologic risk factors. It's so important to take this history. Premature menopause, especially early on. History of pregnancy-associated conditions such as preeclampsia or low birth weight in offspring. High-risk race or ethnicity such as South Asians. And then there are these biomarkers that we talk about that are associated with increased ASCVD risk. And again, one that most people get all the time are triglycerides. If the triglycerides are greater than 175 based on the guidelines, that would be considered an additional risk factor. If measured, but you do not have to measure them, elevated high sensitivity CRP. Elevated lipoprotein A, we could get into a long discussion about this, but I think it is very important. And anyone at risk for heart disease, a family history of heart disease, or a personal history of heart disease should probably have this measured at least once. Elevated ApoB, measures of atherogenic lipoproteins, and markers of peripheral vascular disease, such as abnormal ankle brachial index. It's just as important in all of these patients to focus on a heart-healthy lifestyle. And all individuals emphasize a heart-healthy lifestyle across the lifespan. A heart-healthy lifestyle reduces ASCVD risk at all ages. If you have a patient who has risk at a younger age, starting a healthy lifestyle early can help reduce the development of risk factors, and it's the foundation for ASCVD risk reduction. We recommend screening children between the ages of about 9 and 11 across the board, and if there's a family history of heart disease, of high cholesterol as early as age 2, it doesn't mean we would use pharmacologic agents in patients age 2, but it does importantly remind us about the role of a heart-healthy lifestyle beginning as early as possible. In young adults between the ages of 20 and 39, an assessment of lifetime risk, as I mentioned earlier, is key and important for that clinician-patient risk discussion. And in all age groups, lifestyle therapy is the primary intervention for the metabolic syndrome. So now let's focus on those patients at higher risk for cardiovascular events, those with pre-existing ASCVD, or the secondary prevention population. And the guidelines give us a nice overview of how to think about these patients. And anyone with ASCVD is at high risk. It's important to remember that they should all be on high-intensity statin therapy. And over on the left here, if their LDL is still greater than or equal to 70, the addition of ezetimibe in these patients is reasonable. We also want to, at least as an initial goal, make sure that LDL cholesterol drops greater than or equal to 50%. In patients over the age of 75 who fall into this ASCVD group, but not what we call very high risk, the initiation of moderate intensity statin therapy is reasonable. If they've already been on high intensity statin therapy and doing well with it, there's no reason to decrease that dose when they become over the age of 75, and continuation of that high intensity statin therapy is reasonable. But over on the right, we have this group that's been identified as what we call the very high-risk ASCVD patients. These patients require high-intensity statin therapy or maximal statin-tolerated therapy as the initial therapeutic intervention, just like those with ASCVD not at very high risk, followed by the initiation of ezetimibe if their LDL cholesterol is greater than or equal to 70. If their LDL cholesterol remains greater than or equal to 70 despite the use of statins and ezetimibe, the initiation of PCSK9 inhibitor therapy would be the next step. However, I point out that there also is another route you can take, and you can go directly from high-intensity statin therapy to a PCSK9 inhibitor, and that's really the art here of medicine and the importance of the discussion between you and the patient, and also consideration about the degree of LDL lowering that may indeed be required. So who is this very high-risk ASCVD patient? It's someone who's had 2 or more major ASCVD events, recent ACS, history of MI, other than the ACS above, history of ischemic stroke, symptomatic peripheral artery disease, or one of these major ASCVD events, and then 2 of what we define as high-risk conditions, age greater than 65, heterozygous familial hypercholesterolemia, a history of a prior coronary artery bypass surgery or PCTA, diabetes, hypertension, CKD, current smoking, a history of heart failure, or, and this one is important, someone whose LDL is persistently elevated, greater than or equal to 100 despite maximally tolerated statin therapy and ezetimibe. That identifies a group at high risk. And so one major event and 2 of these high-risk conditions, which are very easy to accrue. Imagine a patient who had an MI 8 years ago and has been stable and suddenly comes in to see you, and now the patient is 65 years old and their estimated GFR is now 55. That's someone who may not have been very high risk and now suddenly becomes very high risk. And so you can get lulled into kind of the stability of your patients if you don't constantly go back and reassess their risk. And when it comes to lowering LDL, we know that this reduces the risk of ASCVD, and the key component of this are the landmark trials with statin therapy, both in the primary prevention cohort and then the secondary prevention population. And landmark trials show that LDL is strongly associated with increased CVD risk, and that treatment with regards to statins reduces that risk. Statins are the mainstay of therapy, and data from the Cholesterol Treatment Trialist Collaborative, the meta-analysis, reminds us that for every 1 millimole, or close to 40 milligrams per deciliter reduction in LDL cholesterol, there's about a 20 to 25% reduction in major cardiovascular endpoints. Statin-associated side effects do rear their head and make it difficult sometimes for patients to remain on the dose of statin we'd like them to be on or get to achieved or desired LDL levels. And in 2018, the guidelines here in the U.S. Mentioned that a large majority of patients are able to tolerate statin rechallenge with an alternative statin or alternative regimen. And I think it's key and important to make sure that you try several statins before you say, gee, the patient can't stay on these medications. And we do know that the frequency of statin-associated side effects is low. It's infrequent in randomized clinical trials, 1 to 5%. But when we look at reporting rates in clinical settings, it's much higher. It's between 5 and 20%. Whether this is real or perceived, it does impact the ability of patients to remain on desired therapy. What are some of the things that we concern ourselves with? Well, myalgia, as I mentioned there, infrequent, 1 to 5%, but 5 to 20% in clinical settings. New onset diabetes. It really is dependent on the presence of risk factors. And I would tell you, while this is real, I do not believe it's clinically relevant, and we can talk about that more in our discussion. Myositis and rhabdomyolysis is rare. Elevated liver transaminases, it's rare or infrequent. Statins are metabolized by the liver, but they don't cause liver disease. And memory or cognition, again, similar, rare or infrequent and reversible. The effect of statin adherence, I think it's important to remember that high-risk patients who cannot remain on statins have greater risk of not only cardiovascular events, but all-cause mortality. And here we're looking at one such analysis, looking at recurrent MI and all-cause mortality, reminding us that there are 3 levels adherence in this particular analysis compared with no statin therapy. And only adherence that was greater than or equal to 80% was associated with significant reductions in risk of recurrent MI and all-cause mortality, meaning those that could not adhere to statins 80% or greater, based on adherence indices, actually had greater increases in both risk of MI and all-cause mortality. So the high-risk patient who cannot take a statin is even at higher risk. Warning lights or bells should be going off in our mind when we see these patients. Just as important as being able to remain on the statin is how long someone actually stays on a statin. And so in this analysis, we're looking at the association of statin persistence, how long you actually remain on the medication with mortality, and the risk of death in patients with ischemic heart disease who continued or discontinued their statin in the analysis. And what we see here is that for each year, or each additional year of statin therapy, that the patient stayed on the medication, this was associated with an additional 19% reduction in the risk of death. And the odds ratio there was 0.81, and you can see the confidence interval. And the p-value for this trend was significant at 0.001. And so again, guideline recommendations versus current practice. Evidence and new guidelines have advanced much faster than practice patterns of most recent registry and real-world data. High-risk patients are frequently not on high-intensity statin therapy and have persistent elevations of LDL, and increased evidence of non-statin therapy to lower LDL cholesterol further have led to changes in all of the major guidelines. But there is very little utilization in clinical practice of combined therapy for lipids despite extensive use for hypertension and diabetes.
Great, thank you, Jamie. That was an excellent overview of the guidelines and where we stand and how to risk stratify, how to assess risk, and how to move forward with optimum treatment based on level of risk. So we've seen what we should be doing in the current guidelines, and there is obviously an exciting time ahead of us because there are many new therapies that are coming through to fruition and development and being approved. So among those are novel therapeutic approaches, and specifically approaches that target PCSK9, which is a potent add-on to statin therapy, but doing this through different mechanisms of action. So I'm going to talk about that a little bit more and about how these therapies can fit in and where these might be added to future therapeutic pathways. So I'm going to really start off by asking the question, is there a need for additional therapy? For such a long time, statins were the standard of care. But what you saw very nicely in the previous talk is that with emerging evidence, we know that lower is not just better, it's also safe, and it's appropriate for those at highest risk. But that also means that the background or the baseline level of LDL in the population around the world, that hasn't really changed. What we have done is that we are progressively moving those goals further and further south. And you can see from a variety of different registries that when we make goals relatively easy to achieve, inevitably we get there. And that may be insufficient for many people, particularly those at highest risk. So compared to low-risk individuals where the goal might be an LDL below 160, where we get there in more than 90 or so % of places of patients around the world, when we aim for goals less than 70, that's much, much harder, particularly all around the world with a monotherapy-based approach. And we might get there in about a quarter to a third. And it doesn't really matter which part of the world or which registry you look at. The pattern is very much the same. And of course, the obvious thing is that if you don't treat, you can't achieve any of these goals. So the first thing to lower LDL cholesterol is to get our patients at least onto some form of treatment and then work out what the next steps should be. So if we look, for example, at a very large US-based registry of almost 50,000 individuals from about 241 practices, we see that we are using statin therapy in approximately 2/3 of our patients, but only about half of those individuals are actually receiving high-intensity statins. Now, even though ezetimibe has been around for a long, long time, its use is under 10%. And when you look at statins being combined with ezetimibe, it's about 6%. When you look at PCSK9 inhibitor use, it's about 1.5%. But combination therapy with a statin is only half of that, 0.7%. And if you look at 3 drug combinations, for example, perhaps these are individuals with familial hypercholesterolemia where they start at very high levels, the use of that is only about 0.3%. So if you look at how clinical care and clinical practice varies across practices, and here we can see random practices being selected in this particular study. And we'd all agree that individuals with an LDL cholesterol without the need for risk stratification, with LDLs above 190, should be receiving statin therapy and indeed should be receiving high-intensity statin therapy. But if you look at the proportion of individuals at each of these practices with LDLs above 190 that were either receiving a statin or high-intensity statins, this should really be close to 100%. But you see this wide variation. And that is something that I think we will need to think about improving on long term. Now, if you look at control of medications and why we sufficiently fail or we fail sufficiently to get to these low levels, we can look at registry data and we can ask questions like, well, is it knowledge, is it beliefs, or is it something else? So in this regard, the Gould registry really is very insightful, because here 2/3 of physicians believe that lowering LDL cholesterol to below 50 milligrams per deciliter is going to be a good thing in these high-risk individuals. But when you look at what proportion of patients achieve levels below 70, it's about 30% and less than 10% below 55. So we're seeing this disconnect between, if you like, belief, values, and implementation. If you look again at use of high-intensity statins, it's about 2/3, ezetimibe 8%, PCSK9 inhibitors 3%. What was interesting was in a recent a study from Sweden, the Swedheart Registry, which is a national registry of myocardial infarction. This study looked at individuals with myocardial infarction how they were managed, and invariably this was with use of high-intensity statins with very little use of combination therapy. And you saw earlier on in Jamie's presentation about the sequential pathway, the addition of ezetimibe and then PCSK9 inhibitors if needed. So in theory, through modeling, they were able to show is that if you optimized statin use, if you then added in ezetimibe, and if you then added in PCSK9 inhibitors, you'd probably have to do that in somewhere close to 100% of patients. 76% of individuals would need ezetimibe, and about half would need PCSK9 inhibitors to get to those low levels of below 55 for those people with established, well, these are all MI patients, so all established cardiovascular disease. So I think that the key mantra for us that we haven't done is we need to talk combination therapy, and we need to talk about intensive lipid-lowering regimens rather than just intensive statin therapy, because intensive lipid-lowering regimens could be 80% when you combine two drugs together. So we've got to become much more like our hypertension colleagues who have been using multi-drug combinations to achieve better blood pressure goals for over a decade. So why PCSK9? Well, we can start with some genetic studies and Mendelian randomization data, and in the Dallas Heart study, for example, and ARIC, and in studies like this, we were able to see that basically based on a loss of function of PCSK9, which is a little bit more common in certain ethnic groups, there is a population distribution of LDL cholesterol, which is lower. So when you have less PCSK9, your LDL cholesterol is lower. Now, if you do genetic studies, you're looking at a lifetime exposure to a lower LDL cholesterol. And these individuals who, by virtue of having less PCSK9, lower circulating cholesterol levels, had a lower risk of cardiovascular disease. Now, this is much greater than we could imagine in clinical trials, because what you're looking at is a lifetime difference, and usually in trials we're only looking at 5 years or so of treatment. The second important thing, and it's a really key thing to remember about absolute risk reductions with therapies, and there are two determinants of this. Firstly, because of the cholesterol treatment trialist collaboration and that data showing that there is a log linear relationship between relative benefit and absolute reduction in LDL, the first thing you need to look at is what is the LDL cholesterol. So if you basically have two patients with a similar global risk, but they have differences in LDL cholesterol, because the percentage reduction in LDL with any therapy is constant, but if you apply that percentage reduction starting with a higher baseline LDL, you gain a bigger relative benefit because it's that absolute reduction that's going to determine relative benefit. You get a smaller number need to treat, a bigger absolute benefit. Now, even when you have those comorbidities and you've got this high-risk patient, if the LDL is a little bit lower, then that same percentage reduction in LDL cholesterol gives you a smaller absolute reduction in LDL and therefore a smaller relative benefit. So when you apply that reduction to baseline risk, you get a slightly smaller absolute risk reduction. So the paradox is that if you have a patient with high risk and a lower LDL, you actually need to think about a much more powerful treatment to get a bigger absolute reduction from that starting level to achieve a bigger absolute benefit. On the other hand, if you basically look at a scenario where you are comparing two different individuals with different absolute risks, but with similar baseline LDLs but different absolute baseline risks, if you add any given treatment, PCSK9 inhibitor, statin, or so forth, because the percentage reduction that you get from the same baseline LDL in terms of benefit is constant because they'll get the same absolute reduction. The benefit simply depends upon what your starting level of global risk is, if you will. So when we look at our patients, there are two determinants. One is baseline risk, and the other is the starting level of LDL, because that will determine the treatment efficacy of your add-on therapy. So the first evidence that actually going beyond just a statin and using a non-statin lipid modification therapy is beneficial was really from the IMPROVE-IT trial. And this was a fairly well-treated patient population. The control group had LDLs of about 69. So virtually everybody is within the current standards of practice after an ACS event. Now, when you add ezetimibe, which gives you 20 to 25% further lowering of LDL cholesterol, to a group already starting with a low LDL, the absolute reduction is going to be about 15 milligrams per deciliter when you add in ezetimibe, and that's exactly what was seen. But if you maintain that small difference over a period of about 7 years, then what you are seeing is a relative risk reduction that was exactly predicted by the difference in LDL, and overall a 2% absolute benefit. But you remember the ACS patient population is a very heterogeneous group. There are some people with additional comorbidities like diabetes, polyvascular disease, recurrent events, CABG. And these are people that got even bigger absolute benefits than what was observed in the overall average of the trial population, because with higher baseline risk comes greater benefit. So let's also now think about real world for a second, and implementation and practice. So we often think about new treatments and going straight for those new treatments, but we need to do the basics right. So if you look, for example, at registry data, so this is a cohort, for example, of 630,000 or so individuals who fulfill the Fourier criteria, so a MAB trial. And if you look at what background therapy is being used, now in the Fourier trial, about 2/3 were on high-intensity statins. Here, this is more like 50%. And what we also see is that the use of ezetimibe is actually fairly low. It's of the order of about 2.6%. So in this patient population, even before reaching out for new treatments, we've got to do the basics right, because if we actually optimize the use of ezetimibe, for example, in that patient population, this cohort, many of these individuals would get to goal without needing to reach out for newer treatments. So we've got to get the basics right, first of all. So let's move towards PCSK9 targeted therapies. Why is it so important? And really for that, you've got to remember, I think, that the combination of a PCSK9 lowering agent together with something that increases LDL receptor production is really the most potent combination that we might have. Why? Well, when you give somebody a statin, what you are doing is you reduce intracellular cholesterol in the hepatocyte, in the liver. And the way that the liver responds is it makes more LDL receptors. But at the same time, what the body does is to produce more PCSK9, and this protein breaks down the LDL receptors. So in an ideal world, what you want to do is have more LDL receptors, and you also want these LDL receptors to live longer or survive longer. And when you do anything that brings down cholesterol levels, because the body, particularly from the liver, pushes out PCSK9, what you see is that you don't get that added benefit from just increasing doses. And this is why combination therapy, particularly with therapies that make more LDL receptors, together with therapies that increase the durability of those LDL receptors, I think are going to be the most powerful combinations that we currently have. So let's look at the biology. The current approach that we have to targeting PCSK9 is with a monoclonal antibody. So what we can see is that if we choose a dose of a monoclonal antibody of 21 milligrams, injected every 2 weeks, the amount of free PCSK9 in the circulation falls. And as a result of that, we see a corresponding reduction in LDL, but the amount of reduction in LDL is not as great as the reduction in PCSK9. So you reduce PCSK9 by 60%, LDL may come down by about 20%, and it will seesaw back up. So if we give more drug now 70 milligrams, for example, with a dosing frequency of every 2 weeks, we get a bigger reduction in PCSK9, so we get a bigger reduction in LDL. But essentially, there's not enough drug circulating for 2 weeks to allow a smooth curve, if you will, between dosing intervals. So you see this spike back up. So now if we inject more drug, if we were to use 140 milligrams now every 2 weeks, we don't get much more PCSK9 being bound. However, there's enough drug in the system to mop up any PCSK9, for example, being produced by the liver for the next 2 weeks to allow a fairly steady state and a steady reduction in LDL cholesterol and to maintain that. And then we have to repeat the cycle again in 2 weeks because there isn't enough drug left in the system to keep mopping up PCSK9. So if we go to now trial data, so that's all great, and we believe that LDL is a surrogate for cardiovascular outcomes, but we still need those outcome trials before we can say, yes, doing this will also translate into events. That was really shown by the Fourier trial in stable ASCVD patients. These individuals need to be on maximum tolerated statins, and the average follow-up comparing evolocumab to placebo was about 2.2 years, with a broad MACE endpoint. And you can see that overall, the percentage reduction in 3-point MACE, for example, was about 20%. But remember that the benefits of treatment accrue over time. So the first year after any lipid-lowering agent, you get about half the benefit. So in the first year of treatment, you've got about 19% relative risk reduction. Now, in years 2 onwards, the curves continue to separate. And now what you can see is that the relative benefit is of the order of 33%, with bigger absolute benefits as well going further out. So the key with all of these treatments is long-term treatment to prevent future cardiovascular events. It's always good to get validation. And there was a second trial that was done with another PCSK9 inhibitor. In this case, alirocumab. This was Odyssey Outcomes. This was a post-ACS patient population. Individuals need to have an LDL above 70 despite maximum tolerated statins, with good use of high-intensity statins in particular. And the follow-up was a little bit longer, but still the average follow-up wasn't of the order of 4 or 5 years like the statin trials. And here in this patient population, we saw a 15% relative risk reduction in a 4-point MACE endpoint. There was also a mortality reduction, which we'd have to consider as being nominal. So are there novel therapeutic approaches to lowering LDL cholesterol? So this slide is really quite useful in terms of being able to show you, and it's a really important reminder, the most efficient way that we have for reducing LDL cholesterol is actually through the LDL receptor. And if you were thinking about a match made in heaven, what you would want is, 1, to have a treatment that made more LDL receptors and have something else that made them survive longer. Now, why do I say that? Well, statins and also bempedoic acid work by reducing intracellular cholesterol. They stop the making of cholesterol within the hepatocyte. Now, the way that the hepatocyte responds is it makes more LDL receptors. They have to be made. There isn't a magic pool that gets pushed out the day after you take an oral medication. So we see this kind of lag before we see the maximum effect. Now, that would be great if we didn't have PCSK9 also being produced by the liver. And what this does is that even though we're making this extra pool of receptors on the surface of the liver, which bind LDL cholesterol and remove it from the circulation, these reduce the lifetime or the life expectancy of the LDL receptor. So now we have LDL receptors that are working really hard, but they don't last as long as we would like, and therefore we kind of get this ceiling of a therapeutic effect with monotherapy. So because PCSK9 is made in the liver, we have a couple of different approaches to lowering this or to targeting this. The first basically is focused on binding everything in the circulation. So if you like, what a MAB does is after you've injected it, it's like having a big bucket that is just catching all the PCSK9 out there. And when the bucket is full, in about 2 weeks, you replace the bucket with a new bucket. In contrast to that, because the liver is leaking out PCSK9, and remember, 80% comes from here, we just switch the tap off. And that's something that we call gene silencing. So what we're trying to do here is not really silence the gene, but the message, because the message is what gets translated into proteins. And there are two basic approaches that we use. These are RNA-based therapies, meaning they're injectables, and they're either antisense or small interference RNA or small interfering RNA. So what's the basic difference? Well, both of these are seeking out complementary messenger RNA. But in the first case, the antisense, the site of where that is working is within the nucleus. So after you inject the compound and it gets into the liver, it has to get into the nucleus to be able to bind to any complementary messenger RNA for its target that the DNA effectively is pushing out. And then these messenger RNA transcripts are catalyzed. So one, if you like, sequence of drug can break down multiple messenger RNA transcripts, and that's what gives it a longer duration of action. But this approach probably needs a dosing frequency of about once a month. It's currently being tested for LPA lowering. On the right-hand side, we can see small interfering RNA, and this works in the cytoplasm. Now, all mammalian cells possess something called the RISC complex, or the RNA-induced silencing complex. So what your cells are doing is in the cytoplasm, they are binding small double-stranded RNAs, and they are switching off gene products that the body doesn't want. So it's a natural process. It's happening all the time. We can tap into that. So what we can do is give it a target to follow. And we do that by creating a 23 nucleotide double-stranded RNA strand, as opposed to the antisense, which is single-stranded. So once this now gets into the cytoplasm, the two strands separate, the antisense strand gets retained by the RISC complex. And it's that binding of that single antisense strand to the RISC complex that gives us potentially a highly efficient system. Now, this discovery that the liver expresses a receptor called Acela glycoprotein, and the natural function of this receptor is that when our cells age and they senesce, they express N-acetyl-galactosamine. And it's that is bound to the Acela glycoprotein receptor and goes inside the hepatocyte. That's how senescent cells are removed. So we can tap into this process again. We can artificially add this N-acetyl-galactosamine onto the inclisiran molecule. And therefore, we can have a very small volume of drug that we inject, and it's all taken up by the liver within about 4 hours so that nothing is detectable in plasma. So this is the same data in a little bit more detail. That double-stranded 23 oligonucleotide strand enters the hepatocyte through the GalNAc modified, or through the GalNAc modification, the Acela glycoprotein receptor. Those two strands have to separate. The sense and the antisense strand have to separate, and that's done with an enzyme called DICER. And then once incorporated into that RISC complex, it's that gives it that long duration of action. So it's not like the drug, there's a lot of drug that's being retained, or we're having to inject a lot of drug. We're only injecting a small amount of drug into the body. But because that small amount is enough, because once it binds to RISC, it just keeps on ticking. It's like one of these toys that you've wound up that will keep on going for a long time. So the first thing to do with any drug and drug development is to find both a dose and a dosing interval. So this was our phase 2 study, Orion-1. And what this shows you, first of all, is that this is a single dose injected on top of statins, or a population on maximum tolerated statins. We've tested 200, 300 and 500 milligram doses. And you see 500 milligrams is no better than 300 milligrams. So you can throw that one out. We don't need that. The second thing that you'll see is this long duration of action. So you get this peak effect in LDL reduction within 30 days, and there's this slow, steady return towards baseline. So what is the true effect of the drug? Is it at 60 days, where you've got a 50% reduction, or 180 days? So what we did when we wrote this paper, and I coined the term time average reduction, because what's important is the area under the curve. So over 9 months, you get a 41% reduction in LDL cholesterol. So now, in the 2-dose arm, we don't usually test the highest doses. We test a lower dose just more frequently. So here we've got 100, 200, and 300. And the second dose is given now at 90 days. And what you can see now is that you get a little bit more LDL reduction, but that's not where the gain lies. The gain lies in the duration of the effect. So over a 9-month period, 270 days, your time average, or your area under the curve, is 50%. And with the eye of faith, you can see that at day 270, you're kind of getting back towards the same level as you were at day 90. So perhaps with that second boost at day 90, we can move out to a 6-monthly dosing interval. So you can see the 1-year data from the same study, where there is really this unique duration of effect because of that specific mechanism of action that I highlighted. And all the second dose gives you is it just gives you that steady state, and it gives you the opportunity in 2nd and 3rd years of less frequent dosing. So on the left-hand side, in the middle, in the blue, you can see that a single dose on top of statins could give you an annual, if you like, area under the curve of about 36 or 38%. And if you only gave 2 doses at day 1 and day 90 and nothing else, and you looked at your annual LDL reduction, what would that be? It's about 46%. But we want to achieve a little bit more, because we're used to talking about add-on therapy and 50% reduction. So how should we potentially dose? So what we basically did was, from that modeling, we thought that we could dose on day 1, day 30, and 6 monthly thereafter. So over about 18 months, we designed the pivotal Orion 9, 10, and 11 studies, and 10 and 11 included populations with established cardiovascular disease. So on the left-hand side, you can see that even with that infrequent dosing interval, because you're shutting off the majority of PCSK9 production at the source, i.e. the liver, you can maintain good PCSK9 lowering with infrequent dosing. And on the right-hand side, you can see what happens in terms of percentage and absolute reductions in LDL. In the top is the Orion 10 trial, and below that, validation in the Orion 11 trial. So absolutely identical results. Safety, clearly for a new drug, we're not used to seeing drugs with long duration of effects. So again, let's look at the safety. Let's remember that it's a very specific mechanism. It's in the hepatocyte and it's bound to the RISC complex, targeting only mRNA and nothing else. So unsurprisingly, when you look at serious adverse events, for example, there is no difference between placebo or inclisiran in any direction. If you look at cardiovascular events, this is not a body count, not an outcome study. We see favorable trends. We need to wait for Orion 4 and wait for the outcome data from that before we can definitively say that. As with all injectables, you see a small excess of injection site adverse events that are mild, moderate, transient in nature, and none of these are persistent. Most reassuringly, in a population already on statins and often on other multiple drugs that work through the liver, even though that the site of this drug is the liver, there is nothing really to be alarmed about in terms of liver safety, kidney safety, muscle safety, or problems with platelets. So again, identical. So why is this such a big deal and why is it so important? Well, the problem that we have with most of our treatments is that they're small molecule based, and we will have to use combination therapy, but here's the challenge. On the left-hand side are 60 individual patients where we've just measured LDL at 2 time points. At the start of the trial, when allegedly they're on a stable dose and allegedly adhering, and we just measured the LDL 6 months later. Half have gone up, half have gone down. That's only biologically, well, it's not biologically possible. The only explanation is if you're more or less adherent between those 2 time points. That is happening every month for the rest of those lives, for the rest of those people's lives. And what that does is that translates into adverse events, because from statin trials, what we do know is people with greater variability have worse outcomes. So we can negate some of that, because even though the patients are on statins and maybe their adherence is less than optimal to that, when we add in the second drug, if that is physician administered or healthcare professional administered, it's in. The patient can't not adhere to it. So that added reduction that you see is going to be observed in every person. And you might look on the left hand and say, well, some people get less reduction. Those people might be less, because we're comparing it to baseline, they may be less adherent to their background therapy, and that's why it might appear as if they have actually got less adherence. And similarly, the people that appear to be hyper responders may be at the later time point, in addition to the inclisiran effect, what you're seeing is being a bit more adherent to the effect of statins in the background. So the overall picture is probably much, much more homogeneous, and everybody can respond if you are the one administering it. Could this change population health? Absolutely, because there are 2 determinants on the left-hand side in the top panel of LDL in our population: what you, the physician and the doctor, prescribe, and what our patients do with it. So if you prescribe high-intensity statins and the patient adheres, you get the biggest reduction in LDL. Similarly, irrespective of what you prescribe, if a patient is non-adherent, you're on the left-hand side. And that tracks below with reduction in risk of cardiovascular events. So if you look at new case of CVD and population health on the right-hand side, what we observe is that top curve. Those are the absolute cumulative events occurring when we prescribe in a certain way and patients behave in a certain way. With optimal prescribing and optimal adherence, we'd prevent about 12,000 events for every 500,000 people with a new diagnosis of ASCVD per year. So what this therapy, inclisiran, does is it's not only potent, but that infrequent dosing, particularly if it's physician administered, will do 2 things. Firstly, you get the additional reduction, but that improved adherence gives you effectively longer sustained cumulative exposure. And that's a double win. And we've never had that before with any therapy. So it doesn't matter how, you saw very nicely from Jamie's talk, that it really doesn't matter how you lower LDL cholesterol. You could, in theory, if you were looking at just one therapy, you could do it with 365 pills a year, 26 injections of a mAb, 2 injections of an siRNA, maybe vaccines, and gene editing in the future. And all you're really changing is adherence through these different approaches. So by optimizing adherence, you're actually going to get a better LDL reduction. So if you look on the right-hand side over a 5-year time horizon, if you get a better area under the curve, you will get a bigger relative risk reduction. And if you now project that to a 52-year time horizon, you're going to get way bigger population benefits than we could achieve with small molecule-based approaches alone, even if they were combination therapies. So really, now as we move towards healthcare strategies and healthcare systems, moving to value-based care and population health, these newer therapies like inclisiran may well help to change our strategies and this whole concept of value. And the primary benefit that we're likely really to see is not just the percentage reduction in LDL, because we've got other treatments that can do that, but it's really related to this impact on long-term adherence. So really my take-home messages are LDL lowering is still central to prevention of atherosclerotic cardiovascular disease. PCSK9 directed therapies, particularly when they're added on to therapies that increase the expression of the LDL receptors, are that match made in heaven because they make and sustain more of these LDL receptors. We've already got good evidence that targeting PCSK9 through mAb-based therapies reduces cardiovascular events. And we have a new class of therapy, which is siRNA-based approaches, which will switch off the hepatic tap, if you will, for PCSK9. And this will allow us a 6-monthly long-term dosing schedule, so twice a year. There's clear evidence that effectively these drugs are not only effective, but are safe, apart from a small excess of injection site adverse events. So I hope you enjoyed that segment, and all of these things are really great, but at the end of the day, we're about patients, and we need to bring all of these things back to the patient. And there is no better person really to put all of this into context than my good friend and colleague, Alan Brown. He hails from Illinois. He has, again, this distinguished CV. But what I really like about him more than anything else, other than his sense of humor, is the fact that he actually can really rationalize complex cases and complex, difficult decisions in a really simple way. So, Alan, I'm going to hand over to you. Please, can you tell us about the clinical implications of current and emerging lipid-lowering therapies? Over to you, Alan.
Yeah, thank you, Professor Ray. And what a fantastic couple of presentations by Dr. Underberg and Professor Ray. They were very clear and very in-depth. So I'm going to try and bring it back to clinical situations and start with a case that's, believe it or not, very common. So this is a 62-year-old female. She has 3 children who've never been tested for dyslipidemia. Why? Because no one's ever suggested to her that they need to be tested. She has a history of hypertension and hypercholesterolemia. And she was referred to the lipid clinic because she had myalgias on atorvastatin, Simva, Prava, Fluva, and rosuvastatin. So she's been tried over the years on multiple drugs and had muscle aches by multiple physicians. She doesn't want to take statins again. And she has a strong family history with a mother who had premature heart disease at age 46. So you can see that she's currently on lisinopril, chlorthalidone for blood pressure, amlodipine for blood pressure, and the only lipid-lowering agent is ezetimibe. And take a look at her lipid profile. She's got a total cholesterol of 336 with an HDL of 40, triglycerides 130, and LDL cholesterol of 270 milligrams per deciliter. So the reason this case is so important, though many of you may be gasping at those cholesterol levels, is that this is a very common scenario. About 1 in 250 patients have heterozygous familial hypercholesterolemia. Now, you should start thinking about that disorder when you see LDLs over 190, but that by itself does not make the diagnosis. If you look at patients with LDL over 190, only about 2% of those will have genetically proven familial hypercholesterolemia. On the other hand, when you have a first-order relative who has similar lipid levels, or premature heart disease in the family, or physical findings such as tendon xanthomata, then all of a sudden the percentage of patients with those LDLs over 190 that have familial hypercholesterolemia goes up dramatically. So this goes back to something that Dr. Underberg stressed in his presentation, the importance of a good history and a good physical exam. How common is familial hypercholesterolemia? As I mentioned, about 1 in 250 people, so you will see it. And I guess the first question is, do you really need to know the diagnosis? Because nobody is going to leave this patient's cholesterol at 336. But there's a subtle point here that she has 3 children. And because the many physicians who have seen her in the past did not know the diagnosis, nobody has asked her to screen her children. So this is a true story. I met this patient for statin intolerance, not for the thought of familial hypercholesterolemia, and I told her that she likely had familial hypercholesterolemia and suggested that she immediately get her children tested. At the time of her first visit, she had 2 daughters who were in their 30s and a son who was 28, who she was very proud of because he was an Army Ranger. So I told her, you need to have those children tested immediately with a lipid profile because there's a 50-50 chance that one of the kids or all of the kids might have inherited the dyslipidemia. And I explained to her that it was an autosomal dominant inherited trait, so if they had the gene mutation, that they would have very high cholesterol. As is often the case, her 2 daughters immediately went and got tested. They had normal lipids, so they did not inherit the trait. Her son told her that her son had told her that he had had at least 2 physicals in the Army, and they would have told him if he had high cholesterol. Now, I know from sad experience that they do not measure cholesterol during screening of Army recruits. And unfortunately, her son passed away about 1 month after we had that conversation of sudden cardiac death during an Army Ranger exercise. And I have no doubt this was due to familial hypercholesterolemia. So the takeaway point from the diagnosis here is think about it when the LDL is over 190. It's much more likely, as you look at what are called the Dutch criteria for clinical diagnosis, as the LDL goes up higher and higher above 190. So an LDL of 250, for example, like this patient with 270, would make it much more likely they actually have the genetic mutation associated with familial hypercholesterolemia, which is most commonly a mutation in the gene for the LDL receptor. And then secondly, do the physical exam, look for xanthomata, and finally, screen the children. So for those patients, though, who have statin intolerance, and as Dr. Underberg pointed out, it sort of doesn't matter whether you believe it's real or not. If the patient believes that they're intolerant to a statin, then no matter what you tell them, they're not going to take it. So I think it's sort of futile to try and convince the patient that their symptoms are unrelated if they are already convinced, and you end up changing to a different statin. And as was already pointed out, you don't want to give up with 1 or 2 or 3 statins. Going back to statins that are not marketed so much anymore, like lovastatin and fluvastatin and pitavastatin, you can get many patients to tolerate the medication. And again, when you add combination therapy, as Professor Ray pointed out, you can get many of these patients below their targeted threshold of LDL. And again, this is most important with high-risk patients where the benefit from treatment is so great. You can also use lower statin doses, particularly in the longer-acting statins like rosuvastatin and atorvastatin, and give the statin twice weekly. Many patients can tolerate 10 or 20 milligrams of rosuvastatin twice a week, or 20 milligrams of atorvastatin twice a week. And then adding daily ezetimibe to that, you can get pretty satisfactory LDL lowering and fairly sustained LDL lowering. And then finally, we talked about, for those high-risk patients, switching to a PCSK9 inhibitor, ezetimibe, and now we have bempedoic acid, which by itself lowers LDL about 17%, but when combined with ezetimibe, can give you about a 38% LDL lowering. And then we don't forget bile acid sequestrants, which many years ago were shown to reduce cardiovascular events. So a couple of clinical pearls. Don't forget that statin toxicity and adverse events can be reduced by avoiding concomitant therapy that may increase risk. There's been this temptation to use gemfibrozole because it's inexpensive, and some places have only that on the formulary. We don't want you to use gemfibrozole with statins. That increases the risk of serious myositis significantly. But keep in mind that twice weekly or intermittent dosing, every other day, for example, of the more potent statins at low dose is quite effective, especially when ezetimibe is added. It is true that side effects are associated with dosages with statins, so lower doses are generally less likely to cause adverse events. And as I mentioned, certain statins may be less likely to cause myalgia. There was only one head-to-head study that I'm aware of that was published many years ago before rosuvastatin was out, and it suggested that fluvastatin might cause the least myalgia. I would point out that pitavastatin was not on the market at that time either. So we don't have head-to-head trials recently, but our experience has been that certain statins may be less likely to cause myalgia, and my advice would be to try several. And then, of course, if you can't get the patient on a statin, consider non-statin therapy, as we discussed. So speaking a little more on familial hypercholesterolemia, the genetic disorders that primarily affect LDL are, as we mentioned, familial hypercholesterolemia. The common one in 250, is the heterozygous form, where you receive one mutant allele from one parent and a normal allele from a second. Again, the most common mutation by far is a mutation in the gene that codes for the LDL receptor. So if you have a mutant allele and a normal allele, about half your LDL receptors are working, and that doubles the LDL in the blood. Very rarely, two heterozygous FH patients will get together and have children, and there would be a 1 in 4 chance that one of their children would get both mutant alleles and have no functioning LDL receptors. That's very rare, about 1 in a million. It's terribly devastating because cholesterols are over 1,000 in those kids, and they often have symptomatic heart disease in the first decade of life. Now, with the heterozygous patients, there would be a 50-50 chance that you could pass that on to your children, and that was my concern with the patient in the case. Much more rare mutations that can look like familial hypercholesterolemia is a defect in the gene coding for ApoB or a gain-of-function mutation in PCSK9. Autosomal recessive hypercholesterolemia is sort of a different animal. Both parents are carriers. They don't have high cholesterol, and the person who gets the disorder has extremely high cholesterol that's resistant to therapy. That's a topic for another day because the mutation is not in the LDL receptor gene or ApoB. It's a mutation in the anchoring protein called the LDL RAP protein. So it's very important to screen cholesterol on everybody, at least by adulthood, meaning age 18, and more important to screen cholesterol in younger individuals when a parent has very high cholesterol in order to pick up familial hypercholesterolemia. So let's get back to our patient. You would want to consider her for familial hypercholesterolemia. It would be an excellent thought to get genetic testing on her, and we would do that either with a saliva test or a blood test. Both can be done in the office, and if you don't have blood testing available in the office, you can get kits for saliva testing and have them available in a prepaid mailer to send into the laboratory of choice. You would certainly consider an addition of non-statin therapy and leave this patient on ezetimibe. So she had no interest in a statin. Because she has familial hypercholesterolemia, she'd be a good candidate for a PCSK9 inhibitor, then we would expect to see outcome benefit. You could also consider bempedoic acid, which is indicated in patients with familial hypercholesterolemia or atherosclerosis, and continue that with her ezetimibe, but it would be less likely that you're going to get her LDL adequately lowered in this particular case with such a high LDL. And as was discussed beautifully by Professor Ray, we have new drugs on the horizon, such as inclisiran, that could be very effective for this patient. So what are the takeaway points from this case? That familial hypercholesterolemia is much more common than most of us realize. Unfortunately, 90% of the patients are not diagnosed, just as this case, where the patient had seen multiple doctors for statin intolerance and nobody told her to screen her children. Genetic testing helps to assess the risk because if it's positive, you have 22 times the risk. If it's negative, you have about 6 times the average risk, both which warrant aggressive therapy. Aggressive treatment is necessary starting at an early age in patients with FH, and cascade screening in families is critical to avoid the catastrophe that we saw with this poor 28-year-old son of this patient dying early. And current and emerging treatment options should be able to reduce the burden of ASCVD associated with familial hypercholesterolemia. So let's go on to our next case. This is a 67-year-old man with a history of a myocardial infarction, hypertension, and dyslipidemia. He has had hypertension for 10 years and a prior myocardial infarction, and now he presents with unstable angina. His hypertension has been poorly controlled, and he continues to smoke. His blood pressure is elevated at 142/90, and you can see that he did not have adequate LDL lowering despite his history of coronary disease, which fits into what Professor Ray pointed out to us. It's just unfortunate that this is a common scenario. And though his HDL is very high, his LDL is low. And some doctor told him many years ago that your HDL cancels out your LDL, which is ridiculous. And once a patient has atherosclerosis, the HDL level is irrelevant. And keep that in the back of your mind. If you have an elevated calcium score or any evidence of atherosclerosis, it doesn't really matter what your HDL is. You focus on aggressive LDL lowering. So this patient was on chlorthalidone for blood pressure, amlodipine for blood pressure, aspirin, and a very mini dose of atorvastatin at 10 milligrams. Now, Dr. Underberg pointed out how we define a very high-risk patient, and this patient certainly would be one. You either have to have more than one of the major ASCVD events or one major ASCVD event and more than one of the high-risk conditions listed on the lower part of the slide. This is just showing any major ASCVD event and the fact that 94% of those with a single major ASCVD event will fall into the very high-risk category because they will have multiple additional risk factors that were on the lower half of the slide. And I put the reference there for you to look at. But this makes it much easier. You just have to remember the 4 majors and know that if they have any one of those, they're likely to qualify for PCSK9 inhibitor. And I think this was gone over in the secondary prevention guidelines very well already by Dr. Underberg. So our patient clearly would be a candidate for a PCSK9 inhibitor with an LDL of 120. They're on low-dose statin. You'd want to go up to the high dose. But keep in mind, when you double the dose of a statin, you only get about a 6% additional LDL lowering. So he's on 10 milligrams of atorvastatin, and we'll talk about this a little bit more. If you went to 20, his LDL would only go down 5 or 6%, which would be 6 or 7 points. And if you go to 40 or 80, you're still unlikely to get that LDL below 70. So you can sort of predict that this is a patient who's going to need combination therapy. So going back to this patient, what did we recommend? Well, the patient obviously went to the cath lab with unstable angina, got a stent, was recommended to follow a heart-healthy lifestyle, as one would expect, quit smoking, and would be put on the aspirin as well as ticagrelor because of the stent. High-intensity statin, 80 milligrams. Remember, going from 10 to 80 is only going to lower LDL about another 15 to 18%. And that's not going to get LDL from 120 to 70. You're going to have to lower the LDL almost 50%. So you can consider adding a non-statin, which would give you another 20% or so LDL reduction. Or you could add a PCSK9 inhibitor, which is going to give you a 45 to 60% LDL reduction, which is what this patient clearly needs to get below 70. So what are the takeaway points from this case? In patients with statin intolerance, trial statins before giving up and consider the low-dose intermittent therapy, as we discussed in case 1. Adherence remains a problem, and I think one thing that we haven't mentioned that I would just remind everybody, you should always ask the patient in the office, how are you doing on your medicines? And are you taking your medicines? Keeping in mind that the most important part of adherence is asking and attending to it. Because if you don't ask the patient doesn't think it's important, and you can't identify that there's a problem. And if the patient says, I keep forgetting to take my pill, and I then ask them, what time of the day do you take it, and what do you do every day at that time of day? So if it's a morning medication, they brush their teeth every morning, I hope, and just tell them to rubber band their medicine to their toothpaste. So in other words, working with the patient to try and help them with adherence is very important. High-risk patients require aggressive therapy for lowering LDL if it remains above the threshold, such as 70 milligrams per deciliter, as we've all discussed. And then consider the possibility of urgency to treat early and whether or not that could improve adherence and improve achievement of our goals. And of course, the newer therapies that have been discussed beautifully by Professor Ray can be given at longer intervals and also given by a healthcare provider. And this might improve adherence in the future as we try to look for management of large populations. It won't be 100% because some people won't make the appointment, but you can be sure that if they arrived for their appointment and they received some of these longer-term therapies like inclisiran, when they leave the office, you know they got their therapy. And as Professor Ray pointed out, this could be a very important key to managing large populations in the future. Well, I'd just like to say that I really enjoyed the presentations today by my colleagues. I hope you enjoyed all of the presentations. And now we're going to take a few minutes for Q&A from the audience, and we really look forward to your questions. And I think everybody on the panel will be thrilled to interact with you. Okay, well, I see we have some good questions from the audience. The first question that's come in is there an age cutoff with regard to treatment for high lipids, or is there an age where lipid-lowering therapy is no longer needed? I think I'll tackle that one. And I would say that, this just requires good clinical judgment. We know that patients over 75 do get significant benefit when put on lipid-lowering agents in terms of reduction of cardiovascular events. And you should keep in mind that age is the single biggest risk factor for myocardial infarction and other cardiovascular events. So you would expect there to be fairly high incidence of events at older ages, and that's why any intervention that works is going to yield satisfactory results. On the other hand, once a patient gets into their late 80s, early 90s, if they can't afford the medicines or have side effects or there's some other reason where it doesn't make sense for them to be on therapy, then that's a judgment call. But we haven't found a specific age where we would see no benefit. So I think, again, at real advanced age, you would just use good common sense based on how the patient's doing and what their overall state of health is. So the second question is, can you discuss the impact of high total cholesterol but low ratios, and are ratios not considered anymore? So Jamie, do you want to talk about we've gone from total to HDL ratios, LDL HDL ratios. Maybe you can shed a little light on where the current status of ratios are.
So my concern always with ratios is they can change with movement of either of the two components of a ratio. So I think we're far better served by looking at the components themselves. And we certainly know that in patients who have high cholesterol levels, especially inherited high cholesterol, familial hypercholesterolemia, typically they have very high HDL cholesterol levels because they just have so much cholesterol. HDL is also made in the intestine, and patients who are high absorbers of cholesterol have high HDL. Measuring the amount of cholesterol in the HDL particle pool is not a useful metric to understand the potential benefit or harm of HDL cholesterol. So my thinking is we're best served by looking at the individual components themselves and not using ratios to assess risk.
Now, that makes a lot of sense. And of course, that follows guidelines both in Europe and the United States.
Indeed.
The focus really is not on ratios anymore. So the next question is, could PCSK9 treatment be a potential future vaccine for atherosclerosis? So I know, Dr. Underberg, you have some thoughts on that, and there's some intriguing new research going on. So why don't you take that question?
Right. So I think what the person is trying to ask is, could lowering PCSK9 long term or doing it early in life potentially act like a vaccine or essentially prevent heart disease? And the answer is I think it might. And so longer acting therapeutic interventions, such as you heard about inclisiran, the ability to use RNA based technology, are one possibility. But the other, even more fascinating area for me is the idea of gene editing and CRISPR technology to knock down genes, and in particular, the PCSK9 gene. And there are people working on this, so that if you could essentially turn off the PCSK9 gene at birth or early in life, not only would you be able to treat inherited high cholesterol, but you might potentially be able to prevent atherosclerosis. So it's still in the early stages. It's not science fiction, though, and I think this is something that potentially could be an option for us down the road.
Yeah, that's an exciting development. We'll see how it goes. I think, many of us have talked about what if you put somebody on a PCSK9 inhibitor from the time they were, say, 16 until they were 40, and then maybe you could stop and they would never get atherosclerosis. There wouldn't be enough time left. But that's a pretty difficult study to do, and that's the dilemma is, how do we do trials on those kind of approaches? But the concept would be get the LDL really low during the first half of your life, and you wouldn't have time to develop atherosclerosis during the
Right.
second half.
Absolutely.
So very interesting. Okay, we can tackle this together, which is, are there any long-term issues with extremely low LDL? How low is a low LDL? And are there side effects in getting LDL below 50 or 40? And I think that I'll just start with the fact that, remember, there are genetic mutations, either PCSK9 loss of function mutations or underproduction of ApoB mutations, where patients have extremely low LDLs. And for the most part, they're actually quite healthy. We know that the PCSK9 knockout mutations had some patients with LDLs of 7 their whole life. And the most common side effect of that seems to be longevity. So we have not seen any cognitive issues, any increase in risk of cancer or other things with very low LDL treated with drugs. A few of the genetic mutations where you don't produce ApoB containing lipoproteins do have potential side effects like fatty liver or cirrhosis, but that's a mutation where you don't make lipid particles. We've seen none of that with drug therapy. So we kind of joke that you can't be skinny enough, can't be rich enough, and your LDL can't be low enough. Jamie, what do you think?
Yeah, just two final pieces to that, excellent overview, which is that when we're born, our LDL is the lowest, and that's when everything important is developing, including the brain. And then the brain itself is an independent corporation, and it makes all of its own cholesterol. And so systemic LDL levels don't impact cholesterol levels in the brain. And so again, given all that information, I think if LDL needs to be made low, it can be done so safely. That doesn't mean it needs to be below 10 in everyone, but if you need to make it low, I think you can do that with some degree of confidence.
I have a patient who's 48 years old. He's a 48-year-old male with mild proximal LAD stenosis by coronary CTA. His LDL is 38, HDL 70, and triglycerides 52 on atorvastatin 20 milligrams and aspirin. Would you change the therapy? So my thought on that is this gets into a philosophical discussion about the guidelines. The guidelines are based on clinical trial evidence, right? And in the clinical trials for patients like this with atherosclerosis, they were given high-dose statin. And that's why the guidelines say, well, we've done studies with high-dose statin, and we know they work, and we know what the result will be. So the guideline would recommend putting this person on 40 or 80 of atorvastatin or 20 or 40 of rosuvastatin. And if the LDL went down to 20, I don't think any of us would feel bad about that, right? So every time you double the statin, you're going to get about a 6% additional LDL lowering. So it's not going to go to zero. And even if it did, I don't think Jamie or I would worry about it. So if you want to follow the guidelines strictly, you would bump the atorvastatin up to 40 or 80 milligrams, be happy with those results. It's an asymptomatic patient with a stenosis that's not significant, and hope that the patient didn't progress. And then the challenge is, how do you follow that patient? So you're going to need to do periodic imaging stress tests if there was any kind of symptom at all, but at least every few years you might want to follow that patient with an imaging stress test to make sure they don't get worse. So those are my thoughts. Jamie, any thoughts on that?
No, only that I think the use of high intensity statins really a surrogate for the dose of statin that gives you a large absolute change in LDL. And at the lower end of the scale, you actually need to use more robust lipid lowering to see larger absolute changes, because the percentages are small when you look at low numbers. And so you can kind of assure that by using the evidence-based dose, which is the higher intensity statin that you've talked about. So absolutely.
Yeah, and that's a point you've made many times, and I've always taken note of that point, that as you get LDLs down below 70, the number of events are lower. And so to make a big difference in the event rate, you have to lower LDL even more aggressively than you might at higher levels. So I think that's a very interesting point, and I heard you discuss that first, so I want to give you credit for that.
Thank you.
So the next question is, what does isolated triglyceride elevation mean? And that's the million-dollar question we've been talking about for a lot of years. And how risky is it? So I think when you look at triglycerides, I always say they're like the little man driving slowly in traffic. If you just look at him, he seems innocent. He's going 30 miles an hour. He's slow, but he's not seeming to be in any accidents. But when you get up in a helicopter and look around, people are crashing all over trying to avoid this little old man. So you have to look at the whole big picture. What are the HDL? What's the LDL? And there's a pattern that's been consistent over many, many decades, which is that those patients with low HDL and high triglycerides in the face of high LDL, so that the LDL to HDL ratios over 5 are at the highest risk. So that sounds confusing, but it's going to be your insulin-resistant patients in most cases, the sort of metabolic syndrome, dyslipidemia. And any patient who's got established atherosclerosis, the triglycerides track pretty well with outcomes. So what does it mean? Where would you have an isolated high triglyceride with a normal HDL or a high HDL? Those are people that you want to think about alcohol or oral estrogen. And we don't think that increases their risk of cardiovascular disease. So when you see an HDL over 45, let's say, with high triglycerides, you should ask how much alcohol they're drinking. And if it's a woman on oral estrogen, you certainly don't want to accuse her of being a drinker. But otherwise, in the face of a lower HDL or a high LDL, the triglyceride elevation is a significant risk. And in fact, low HDL, high triglyceride patients are the highest risk of all the patients that we see when it comes to atherosclerotic disease. And interestingly, they got the biggest benefit from LDL lowering in every trial. In fact, they drove the benefit in most trials because they were the ones having the majority of events. So that's a long-winded answer to a question that's not quite as simple as it might seem. And then, Jamie, I'll let you weigh in on that, and then we'll talk about whether we should treat lipids after age 80.
I think you've covered most of it. I think the one thing to remember is that there is a rare condition called glycerol kinase deficiency that causes very high triglycerides because an anomaly in the way you measure triglycerides. So they appear high and you can't do anything to make them go down, and everything else is normal, including the HDL. The way you make the diagnosis is you simply spin the blood and it's clear instead of being lactocin. But it's worth knowing about. It's one other thing that I think makes sense. The other is that the guidelines remind us that isolated triglycerides with normal LDL is a risk factor, and you have to think of it that way. And while you may not necessarily want to intensify medications, it certainly does increase the risk of the patient and should make you aware of that as something that potentially, like a light bulb, comes on in your head.
And I think, several recent articles have brought back the concept of non-HDL or ApoB as a predictor of risk. So triglycerides alone, LDL alone, HDL alone aren't nearly as good at risk prediction as looking at some measure of numbers of particles, whether that be non-HDL or ApoB levels. And so I think we're going to move towards using non-HDL again as a risk, and remembering that number, total cholesterol minus HDL, should be no more than 30 points over your LDL threshold. And that's something to keep in mind to assess the risk of somebody whose triglycerides are elevated. The other question was, should we treat people over 80 years old? And I think we can answer this one quickly. I think that, it depends on the patient. If the patient is in a nursing home with dementia and rheumatoid arthritis, probably not. But if it's a healthy 80-year-old patient who just had an acute coronary syndrome, absolutely. We have a lot of data that over 75, lipid lowering reduces events in the short term. And since age is the single biggest risk factor for cardiovascular events, these are high-risk individuals. So you weigh the benefit versus the risk. You look at the viability of the patient and you make a judgment, but there is no rule that you can't treat somebody over 80 years old. My mother, who's 96, was taking a statin until she was in her early 90s. And then she refused to take her statin, as well as many other things after that. That was her choice. So I think that's all the questions we have. Jamie, any final thoughts?
No, I think you've covered it all. I think in the elderly patients, remember, stroke becomes an important risk factor, and preventing a non-fatal stroke in an older patient is a very powerful thing to do. So I leave everyone with that thought.
Yeah, that's a great one, because the patients will say they're more worried about that than a heart attack. That's a good point. All right, so I'd like to thank everybody for the questions and for your attention and joining us for this conference. I hope you found it enlightening.
This activity has been jointly provided by the University of Florida College of Medicine and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/KXB860. This activity is supported by an educational grant from Novartis Pharmaceuticals Corporation.